This first case was put together by Dr. Rito Barshinger and Dr. Krista Grant, and it is entitled Management of Lung Nodules in Patients with Wilms Tumor. So a 3-year-old presents with an abdominal mass that's consistent with a Wilms tumor. On cross-sectional imaging was also found to have multiple pulmonary lesions. Jennifer, what is the next step?
As you know, primary nephrectomy can alter treatment and impact late effects in patients with metastatic lung disease. Wilms tumor is staged as an abdominal stage as well as an overall stage. Abdominal stage can still be stage 1 or 2 despite the presence of metastatic disease. So even in the setting of stage 4 disease, favorable histology Wilms tumor, local stage is very important. Local stage will impact the need for abdominal radiation therapy, and therefore performing a primary nephrectomy whenever possible and sampling of lymph nodes at the time of nephrectomy is of extreme value, even in the setting of stage 4 disease. Although the pathology of the primary tumor and the metastatic lesion has rarely been reported to be disparate, tissue from both sites are currently not required on current study.
This patient then undergoes a primary nephrectomy and has stage 2 abdominal disease with favorable histology Wilms tumors. After 2 cycles of chemotherapy, the repeat chest CT scans shows complete resolution of the lung lesion. Jennifer, what is the next step?
This patient does not need pulmonary radiation. This patient is considered a rapid complete responder and therefore can be spared the radiation to the lungs. The management of pulmonary disease in patients with Wilms tumor has recently changed. Recent COG and SIAP studies have shown groups of patients, if given chemotherapy with complete resolution of lung nodules, can be spared radiation therapy to the lungs with similar event-free and overall survival to those who did receive chemotherapy and radiation. These are considered rapid complete responders. Importantly, in this study, 46% of patients were spared pulmonary radiation initially. This is a very important graph, as the long-term risks of radiation therapy to the lungs can include diminished pulmonary function, congestive heart failure, and secondary malignancy, particularly breast cancer. Nearly 2,500 female survivors from the National Wilms Tumor Study 1 through 4 were followed long-term for the development of breast cancer. Of those who received pulmonary radiation, nearly 15% developed invasive breast cancer by the age of 40.
What if the same patient following 2 cycles of chemotherapy with DD4A underwent a repeat chest CT scan revealing just a single left pulmonary lesion? Would that change your management?
In this patient, a thoracoscopic biopsy of the pulmonary lesion should be strongly considered before escalating therapy. Several studies have shown that not all lesions have viable tumor. SIAP demonstrated that those with necrosis and non-viable tumor did well without radiation therapy, with comparable event-free and overall survival. On AREN 0533, of those patients who had a partial response or stable disease, 8 patients with stable disease underwent biopsy, of which 7 were not tumor, and 15 patients with partial response underwent biopsy, of which 9 were not tumor. A retrospective feasibility study of 0533 patients were performed, including 80 patients with between 1 and 3 pulmonary nodules. And it was determined that of these 80 patients, 35% met criteria for thoracoscopic biopsy. Therefore, select patients may be good candidates for surgical biopsy and potentially avoid pulmonary radiation. In an upcoming COG study, there will be a recommendation that patients with minimal residual disease, such as 4 or fewer peripheral lesions, be recommended to undergo thoracoscopic resection to determine pathology. In those patients with benign disease or have complete necrosis Wilms tumor, radiation therapy can be avoided, therefore decreasing the risks of late effects.